right. Patent foramen ovale, I suppose, is a good extension beyond the nebulae of stress ECG assessment. It remains one of these awkward aspects of diving risk determination. And what I hope to do is maybe just review some of the information, and I hope that some of the definitions that Tyson's been giving will add some resolution to how we look at this, and perhaps a way in which we can move forward. So I'll touch on these aspects: anatomy, prevalence, diagnosis, impact, treatment, and then close with advice. Oh, by the way, the book over here was one I co-authored with Peter Gebalpré and Tina Balestra and Alessandro Moroni. Basically, I just helped with the English, but it was fascinating working through the material and really see how much is involved in this whole area. Okay, PFO anatomy, I think we're all fairly familiar with the issue. We've got an embryological and fetal development that really permits the passage of oxygenated blood through the inferior vena cava into the left atrium that serves the fetus very well, but then needs to reverse as soon as birth occurs. It may persist for a period of time, and therefore children have an overrepresentation of shunting, and it's one of the potential concerns about children moving into diving too quickly. They may be vulnerable to shunting to a greater extent than adults might be. If you have disruption of the interatrial septum through enlargement either of the right or the left side, there's a greater chance that you will have shunting by disruption of the foramen ovale. And as we mentioned, in the fetus, in utero, it's great, but once they're born, it loses its functionality. Now, on the left atrial side, obviously stenotic or regurgitating lesions would lead to left atrial enlargement and could produce a left to right shunt through a foramen ovale. And the one that we might actually permit to dive would be mitral incompetence. We don't like stenotic lesions, as you know, but incompetence might introduce atrial enlargement and could produce a reverse shunt. Conversely, on the right side, if we have stenotic lesions and pulmonary hypertension, those would then produce right atrial enlargement and, again, possibly precipitate right to left shunting. As you know, sometimes if you've got a congenital heart defect, you need your PFO to basically keep mixing things up so that you can survive with a malfunctioning pump. There's an embryological remnant called the Chiari network that may persist and keep people in a state of partial shunting. So it's really gee whiz information for the most part. And in severe cases, we are familiar with paradoxical embolism that may even occur as a result of a patent foramen ovale. All right, so that for the anatomy background. Let's quickly look at the prevalence, and I think most of you know about the classic Mayo study. Nearly 1,000 autopsies. They found the prevalence was about 30% in that group. And what they also found is that as people grew older, the prevalence decreased, but those that still had PFOs had larger PFOs. So that's pretty much what came out of that study. In a subsequent study of TEE patients, they found pretty much the same prevalence, about 25%, but they found that out of those, half were shunting at rest. In other words, when they did a contrast study, these people were shunting even though they weren't doing a Valsalva. And technically that would mean they had a functional atrial septal defect. And that's really where we're trying to go. Are we dealing with a functional atrial septal defect where a person at rest is likely to shunt, or are we dealing with someone who under certain conditions may be induced to shunt? Because those really are two different categories. Now, yes, there are bubbles after dives. Yes, we know that about 30% of divers will have at least a pro-patent PFO, and yes, we know that some people do shunt even at rest. Now what? Well, of course, we now need to determine, is this an important matter? And Richard Moon in '89 at Duke University was able to show that there was definitely an overrepresentation of PFOs, and large PFOs, because he used transthoracic echo, an overrepresentation in those divers that had serious decompression illness. And towards the end of the presentation, you'll see that that becomes part of our differentiation. What types of decompression illness may lead us to suspect a PFO? One of the intriguing things about PFO is they're not static. In other words, if I test you today and you have one, it's not to say you'll have one tomorrow. And in this particular study by Nge in 2002, they looked at 33 divers that had been examined twice with TEE, transesophageal echo, 6 to 8 years apart. They found a relatively high prevalence, but out of this group of 33 divers, 4 that were positive with the first test were negative with the second. And remember, TEE is our gold standard. So I mean, they failed the very best assessment that could be done. So things had changed for 4 of them. 1 who was positive became negative, and 4 out of 5 that had a small PFO now had a large one. So even if we would decide to screen, it's not to say that what you found today would be there tomorrow. And that's an additional complication. So let's look at the screening and diagnostic components. And of course, there are all kinds of probes and devices that we can attach to people. And what I'll try to do is show you how it breaks out and which we might consider using under which circumstances. Now, Tyson very nicely illustrated the differences between the sensitivity and specificity in terms of either screening or making diagnoses. And for a screening test, we'd prefer not to accidentally miss out on people, so we don't want false negatives. But we also need to consider that it's not a particularly invasive test. If you need to assess a lot of people, you don't know what the yield is going to be, you don't want to stick needles and probes and things in all kinds of orifices and either kill them or inconvenience them greatly, either physically or financially. Now, with that type of perspective, a test that I only became aware of in preparation for this talk is the use of ear pulse oximetry as an assessment of PFO. And I'll show you the article just now. And that is arguably the best screening test there is at the moment. And I'll show you the data. After that, from a practical point of view, carotid Doppler, because it's relatively simple to do and these vascular Dopplers are readily available. After that, transcranial Doppler, although they won't be readily available, it's certainly relatively safe. And if you really move beyond that, from a sensitivity point of view, you could consider transthoracic, but as you'll see, it's not a great test. Once you've decided you need to know, well then you're really stuck with a transesophageal echo. In other words, when you move from screening to diagnosis, you really pretty much have to use a TEE. Okay, so let's walk you down the path of how we've reached the milestones in navigating this tricky area. This is a study by DiTullio in '93. And he had 49 individuals, of which 19 had a PFO and 30 did not. Out of the 19 that had, 15 had a rest shunt and 4 had Valsalva positive PFOs. So that's your population that was assessed. And that was using TEE as the benchmark. They then had transcranial Doppler, and the transcranial Doppler, which basically samples the circle of Willis during the contrast procedure, was able to detect 13 out of the 19 that had been found on TEE. So its sensitivity was 68%. One can add that fortunately the ones it missed were small PFOs. So one could arguably say that transcranial Doppler was comparable to transesophageal echo for significant PFOs from a screening point of view. So transcranial Doppler and by extension carotid Doppler are reasonable equivalents from a screening point of view. The disturbing thing was that transthoracic echo really had a very poor sensitivity, and part of it is because if you've got overweight individuals, it's technically difficult to visualize the chambers of the heart adequately. So it's not really a suitable screening test. And if you get to the point of diagnosis, one has to argue or one has to ask whether it's worth doing that as opposed to a transesophageal. All right, so we're moving towards thinking that transcranial Doppler, from a screening point of view, is a reasonable test. And in the subsequent study, it is certainly better than transthoracic echo. So at least that decision point can be made. A Doppler is, from a screening point of view, reasonable and better than an echo equivalent that is not transesophageal. This is what the TEE looks like. It's somewhat unpleasant. It's basically like a gastroscopy, which makes it technically difficult if the person needs to do a Valsalva, because you've got this pipe down your throat and now you need to do a Valsalva. So it's not particularly popular. It's rather expensive, but if you want a definite diagnosis, that's what you need to do. Now, having the probe in the right place is only part of the story, because now you need to have a contrast agent that will allow you to determine whether there's shunting or not. So what mix do you use? Well, the homegrown variety turns out to be one of the best. And the mix that ultimately has shown to be the most versatile is using 8 milliliters of saline, 1 ml of air, and 1 ml of blood. So essentially you just allow 1 milliliter of blood to flow back into the syringe. You've got the air, and the balance is saline to make up 10 mils, and you slosh it to and fro with Luer locks using 2 10 mil syringes, and it produces a froth that has bubbles that are pretty much in the range of about 30 microns. Now, a red cell is 10 microns, so it's much larger, which for this particular test is useful because it should not traverse the pulmonary circulation. What we want is we want to see any shunts happening in the heart. So we want larger bubbles because smaller ones will actually go all the way through. And that's actually the problem we have with Optison. Very sexy, very expensive, but ultimately useless because it goes everywhere. After 10 seconds, everything's white. So this is Optison. We use it at Duke University, but as I say, it really does not allow us to make that intracardiac shunting distinction. This is what it might look like if you do transesophageal echo. You know it's transesophageal because the left atrium is at the apex of the ultrasound, so it means it's just below the probe. And the only way you get there, other than evisceration, is if you've actually got it down the esophagus. And what you're seeing here are some bubbles in the left atrium. So that's a positive test. What you're looking at here are 2 studies. The first one, same individual, showing only a very small number of bubbles into the left atrium. But very, very few bubbles going through. The next one, you'll actually see more because it's combined with a Valsalva. So if you watch over here, you'll actually see some bubbles going through. So you can actually see that this is a positive test when combined with Valsalva. That's transthoracic. It certainly is less invasive than transesophageal, but unfortunately its sensitivity is pretty poor. But in especially lean individuals, it will be specific. In other words, you will actually be able to see shunting in the heart, which will allow you to determine that it is indeed a foramen ovale or an ASD as opposed to a pulmonary shunt. That's what the transcranial Doppler looks like. So you've actually got a very well stabilized probe, and it assesses the circle of Willis, and it will detect bubble signals when you inject the contrast. And here are 2 intrepid Belgians, Peter Gemonpré, Constantina Balestra, and I think most of you have probably seen this before. Basically, Tino Balestra entered a neurophysiologist and he exited a neurophysiologist, so it didn't have any harmful effects. But what you will see is in the negative test, where he does not do the Valsalva maneuver, there was no contrast passing through. So no bubble signals there. Moving down to the positive test, combined with a 10-second Valsalva. Okay, you heard those signals. So those are merely going into the brain, and that would constitute a positive test. And we'll explain in a moment why we're not particularly concerned with these causing damage, although it's something that one certainly needs to consider. So, safety. Injecting bubbles into people is certainly something that most of us would find somewhat disturbing, but the safety amongst a group of physicians doing this routinely suggested that if there were any consequences, they were transient. Under my hands, I've certainly had a couple of dyspneic patients coughing and one or two visual symptoms that promptly responded to oxygen. So it does happen, but it doesn't seem to have lasting effects. There was a nasty case of a stroke that was produced by contrast that got everybody a little bit ruffled. And then, of course, people like Philip James that have done a lot of work in neurological aspects of HBO are rather concerned about embolizing people deliberately. But the reality is, if you've reached that stage, you're doing it for a defined and reasonable purpose. Okay, so now that we have established that we want to screen or we want to test, what are the issues surrounding a PFO that even make it relevant? Well, size matters, because a small PFO is not going to shunt as much as a large one. So how are we going to determine those parameters? Well, most of the early studies looked essentially at opacification. In other words, how many bubbles went through, how many little white spots did you see on the echo, and was that a reflection of the size of the PFO? Difficult to quantify. Then it was, does it open with Valsalva versus coughing or versus rest as an indication? And using that metric, about 5% of the population have a functional ASD. Bearing in mind that even though we do a provocation test with a Valsalva, is actually a lot less than the type of intrathoracic pressure changes a diver will have by simply doing diving activities. In other words, doing a deep knee bend with a scuba tank over your head, or climbing in a boat, or doing those sort of strenuous exercises would induce far more right atrial pressure shifting than the Valsalva that we would typically ask a diver to do in the laboratory. So we need to be aware of that. Plus, they're in water, so you've got 30% increased venous return, so you've got a lot more blood going into the right atrium. So again, the diving situation is not the same as you'll have with a comfortable couch situation. Lastly, you can of course move into three-dimensional techniques, and ultimately we're at a stage that you can physically visualize the fossa ovalis, and you can make a reasonable assessment with these devices. But that would only be true for people that actually go for TEE. So it's not going to be available from the screening point of view, only once you're going into the diagnostic approaches. Intrathoracic pressure, as I say, the worst would be breath holding and doing a strenuous deep knee bend. That is the worst shunt-provoking maneuver yet described. So clearly, if someone has a PFO, you'd want them to resist going for an immediate bowel movement after they've done their 7-hour trimix dive. Okay. Gentle ear equalizing, on the other hand, doesn't appear to be significant. When you do want to do a provocation test, it requires at least a 10-second Valsalva. And we'll talk about that when we look at this test. I was fascinated to see how little I knew about what had come around over the past 5 years. And in fact, the study that started shifting things in this direction was already published in 2001 in Stroke. But this study from Switzerland, from Bern in Switzerland, actually looked at changes in pulse oximetry as a result of intracardiac shunting. And if you think about it, it's duh, of course that's a great idea. Because if you get right to left shunting, you should get a drop in your arterial saturation values, which indeed they found. How they did it is they took 117 divers with verified non-PFOs and 48 with TEE verified PFOs, and they did a Valsalva release. And the Valsalva release for this procedure is slightly different to the one we've typically done. What we do with the carotid Doppler is we let the person take a deep breath and hold on a full breath. Here they do the reverse. In other words, you breathe in, you breathe out, and upon exhalation, you strain the abdominal muscles. And then keep that for 7 to 10 seconds. In other words, you actually deliberately reducing the oxygenation by exhaling to residual volume. Okay, so you're stressing the system from that perspective, and you're using the Valsalva effect for the subsequent shift in right atrial pressure. When they released after the 7 to 10 second Valsalva, they were able to find that the SpO2 on the right earlobe dropped in excess of 80% of 80% of a percent, or close to 1% on the oximeter. And ultimately, of course, playing between sensitivity and specificity, they were able, at that threshold, to define a sensitivity of 0.75. So using a probe on the ear, you're able to detect a patent foramen ovale at a sensitivity of 76%. That's pretty good. And of course you can tweak it depending on what your needs are, and I'll show you the summary in a moment, but it means that there's a negative predictive value of 0.88. So I think if Dan wants to get into this research, it's a great opportunity. It'll demystify, we can have a massive population of screened individuals, and subsequently, if decompression sickness were to occur, you can then do the TEE, and I think we could really answer the question definitively. So I think we need to move, because we could really lead on this project. Okay, so this is just to show you what the tracings look like. This was the group with no PFO, and essentially what you saw is no major change in saturation when the Valsalva was released. For those with patent foramen ovale, there was a very obvious dip. And this is published in the American Journal of Cardiology, so we're talking about a serious journal, a very, very good study. That's what the device looks like. It's got a printout facility, which is probably the most important feature. And this was the summary in the discussion. Ear oximetry meets the criteria for a screening test: non-invasiveness, low cost, and a relatively high rate of true negative tests. Depending on whether the saturation change threshold in the study was selected at 1, 2, or 3 percentage points instead of greater than 0.8, the test specificity can be increased to 77%. And there you have sensitivity 68, negative predictive value 87, to 89, or to 94. And based on what Tyson was telling us just now, it's going to be pretty neat to be able to play between those two depending on what your objective is, selecting in or selecting out. Okay, so I think that's quite an exciting prospect, and we might finally be able to get some answers. I'm going to ramp it up now quickly and just go through the impact. I think we all know the potential concerns we have here. If you've got shunting, you get bubbles in the systemic circulation, and obviously it's going to go into nasty places. It can go everywhere. So we know that divers are at risk. We know that even on very simple studies that Dan has done, is doing regular dives, 91% of divers have detectable bubbles, and they have that in about 73% of the typical dives they do. And in some of these dives, and in fact almost half of them, they had grade 3 bubbles. In other words, bubbles were there continuously in every cardiac cycle. So we're talking about a significant amount of exposure. We don't assume arterial bubbles because the blood pressure is elevated. Inert gas values are low on the arterial side, and therefore if bubbles are on the arterial side, they got there by a shunt, either in the heart or through the lungs. Is it bad for you? Yes. The study by Schwartzman was able to show that you basically double your chances of having an MRI finding in relation to a PFO, whether you're a diver or not. So divers had a slightly higher incidence of brain lesions relative to divers without a PFO, and even in controls there was a doubling of the number of MRI positive lesions. Essentially saying the same thing slightly differently, Moon and Wilmshurst was definitely able to show that you are likely to get more serious decompression illness with a PFO. And perhaps one of the most useful studies by Peter Gemmonpré was to say that the type of DCI matters. In other words, the type of DCI you get with a PFO tends to be brain, cerebellum, high spinal or inner ear. So in other words, you don't have to consider a PFO with all forms of decompression illness, but only when you truly see paradoxical embolism related to the brain and the upper central nervous system structures. The low spinal cord lesions, the sort of girdle pain, paralysis, those were not associated with a PFO. And of course, if it's an undeserved case of serious decompression illness, our suspicions are raised even more. Now, why PFOs become interesting is because of the associations with stroke. And I'm going to summarize the literature simply by saying the types of PFO that are relevant for stroke are the ones that are associated with a concurrent atrial septal aneurysm. In other words, it's not only bad to have a hole, and in fact the hole on its own is not the problem, it's if it's in a floppy wall. So if the atrial septum is mobile and is floppy, then it is associated with stroke. And as far as size goes, it seems that 4 millimeter PFOs seem to be significant. So those two factors, when it comes to stroke assessment, floppy walls, more than 4 millimeter PFOs are relevant when it comes to stroke. Knuth, who is one of the folks that really is very, very concerned about PFOs, found a lot of lesions and reached the conclusion that before you don your scuba tank, you need a PFO assessment. He's a minority, but he certainly made a case that PFOs are associated with these lesions. And I think you and I all know about divers that have called the Dan hotline, or maybe you've spoken to, that say, well, they had transient visual symptoms after reaching the surface. And are we neglecting to follow up on those cases? Because those may be sort of grace of God cases of transient gas embolism, just like a TIA would be for a stroke. And we should perhaps be more aware of those individuals than being overzealous in screening people for PFOs that don't have typical manifestations of DCI that would be associated with PFO. There's the study between Dan Europe and Dan Southern Africa, which was essentially a carotid Doppler study. People who wanted to know whether they had PFOs came, we injected them with bubbles. If they had PFOs, we wrote it down, counseled them and said, well, just dive as safely as you were meant to dive anyway. But if you happen to get into trouble, we'd like to see you again shove a probe down your esophagus and see whether you actually did have a PFO. So the study is ongoing. The idea was to get 4,000 divers enrolled, because at that sort of level, or with those numbers, you'd have enough incidence of DCI to do the follow-up TEEs. The study is still ongoing technically, but I think it's lost some momentum. And I think this ear saturation option is going to be able to revamp it. And I think it's something we can get divers excited about. It would be something that we could really use to encourage them to dive conservatively and wisely. You can almost think of it in terms of a diver wellness screen. I think it's something we could really use to motivate people, not scare them, but motivate them to dive wisely. And on wisdom, let's quickly look at what advice we should be giving divers. Well, first of all, we know that the rules don't immunize you to decompression illness. 50% of folks that get decompression illness didn't necessarily break the rules, and they're not only lying. it really is quite common to find people not doing anything overtly wrong, getting symptoms. There are many risk factors that we're aware of, but PFO is part of that mix. So what do we do about it? How do we look at this? Well, what do the divers say? Well, the divers say, ask the experts. Well, here are the experts and we don't know. So let's see what we can extrapolate when talking to them. Who cares? Well, the technical divers do. The technical divers don't want bad statistics amongst their teams. They often dive in very challenging situations, so they don't want people with severe decompression illness there. So many of these groups are actually starting to exclude divers from technical dive training because they have a PFO or they haven't been assessed. I know in our country there are at least 2 groups that won't let you dive with them unless you've had a PFO assessment. So there are people that are actually implementing restrictions based on PFOs. Who understands? Well, a lot of garbage, especially on the internet. Some say, oh no, it's very simple. Well, you know, whenever you say that in medicine, you're eventually inevitably wrong. This one says a patent foramen, that's the guy who described it. Ovale is the whole. Okay, so you know you won't necessarily get proper science. You should have the test done, but go straight for the probe. Again, the understanding of screening versus verification would not be particularly reliable amongst the divers. So I think there's a big education call. Then you've got the extremes. No PFO check, no diving. Well, clearly that's not going to wash. To, hold on guys, when are we really concerned? Back to Gemonpre's article, if it looks like a duck and it walks like a duck, then it may very well be one. So in other words, DCI affecting those areas, the brain, cerebellum, inner ear, and higher cervical spinal cord, those are the ones where we think about PFO. And to this, let me add, within 30 minutes, based on Wilmshurst's article. So in other words, rapid onset, neurological signs, or a rash, because skin rashes are associated with PFO, but only the rapid onset ones. Those might flag an individual for PFO assessment. How dangerous is a PFO? I'll summarize Fred Bouvet's meta-analysis of the Wilmshurst, Moon and Cross articles by saying that basically chances of DCI across the spectrum of Navy, recreational and commercial diving is about 3.6 incidents per 10,000 dives, of which 2/3 might be neurological decompression illness. Using that data, the presence of a PFO increases your risk by 1.8 in terms of the average population, whereas the absence of a PFO reduces it to 0.67. So, you know, looking at the low numbers or low chances of getting decompression illness and the additional risk by having a PFO really does not justify screening for the PFO's sake. Now, perhaps now that we've got the pulse oximetry option, it's going to be easier to justify, but nevertheless, the risk increase does not justify screening. But if decompression illness does occur, and it does seem to be typical, or at least associated with the PFO manifestations, then we should do a TEE. As far as screening is concerned, in the SPUMS meeting, Jörg Wendling recommended the carotid Doppler, which is what you saw with Tino Balestra, because it's fairly cheap and fairly simple. If you want to test, so if you want to have specificity, then it's a TEE. And if you want to do screening, well, it's probably better in a research protocol. What do you do if you have a PFO? Well, Drs. Wong and Wright recommended that if you have a diver with a PFO, clearly you do need to counsel them. You would then use the Bouvet data and say, well, you've got that 2.5 odds ratio that Bouvet found. And if they don't want to take up another sport, you could counsel them in terms of avoiding bubbles, and there are ways to do that. And of course, avoid the activities that may increase the chances of shunting. But inevitably you get to the point where someone may ask, well, should I have it repaired? Well, atrial septal defect repair goes back as long as cardiac bypass does, and even before. Now, doing open heart surgery for a PFO is a bit extreme, but fortunately we've got the percutaneous devices, of which the Amplatzer has probably been the most successful and best studied. That's what it looks like once it's been deposited. It's essentially a cardiac catheterization. They shove it through the fossa, or the foramen, and it remains embedded in the interatrial septum. The devices have been tweaked a bit, so they're self-centering. It's a lot better. And it seems that for the most part, within 3 months, about 99% of the PFOs are closed. You may give the person a couple of bumps in the road, some dysrhythmias during the procedure, and there have been some thrombotic episodes in the Mayo experience. But the success rates are reasonably good, and the hospital stay is typically about 24 hours. There have been device embolizations, and people are typically kept on aspirin for 6 months. Whether they should dive in that period is debatable, but that is the practice at the moment. This is an autopsy specimen showing the Amplatzer device epithelialized in the interatrial septum on both sides. So they integrate rather nicely, and they certainly get the job done. Does it help to repair people? In summary, Walsh, Wilmshurst and Morrison did this study, published in 1999 in Heart, and they looked at 7 folks that had serious decompression illness, had large PFOs, had them closed, no problems, and went back to diving with no difficulties. So there are folks that are back diving, even though they had large PFOs, but had them successfully closed. And this is just a typical testimonial. I had the op. It was about 6,000 UK pounds. They went through my thigh. I had to stay in the hospital for a night. Felt a bit bruised for 1 to 2 weeks, but I'm back to trimix diving. Okay, and there are quite a number of cases that have that sort of story. For those of you that are suitably confused after this presentation, I'd like to refer you to an excellent summarizing article. It's an open source article by Sykes, and it's called Patent Foramen Ovale and Scuba Diving, a practical guide for physicians on when to refer for screening. It's really a very, very good review, as well as absolutely dumb it down, this is what you do information. Good value. There's the reference at the bottom again. They recommend the standard diving safety practices, which would be useful for you to perhaps use as a template when counseling divers. They discuss the suggestive manifestations of DCI, as well as migraine with aura, that may represent the presence of a PFO and may move you towards the decision of screening or not. And they are severe, as Gemmelpre found, non-provocative dives leading to serious DCI, the manifestations within 30 minutes of brain or skin, associated migraines with aura, and again, as I said, serious symptoms within 30 minutes. So those are the flags. Then, when to refer or not. Well, we're not referring people that never had DCI, whether they had migraine and aura or not. Okay, so you need DCI before you start thinking of going for further assessment. And if they had that, if they had the severe DCI, non-provocative profile and all the other things, well, then it's justified to have them assessed. And then you do a TEE and possibly consider closure. So, in conclusion, yes, PFO and DCI are associated. The absolute risk for DCI increases by about 1.8 above average population with a PFO. If you have the manifestations that are warning signs because they're associated with a PFO, you should assess these people with a TEE. However, routine screening is not justified. I think the SpO2 is going to give us a whole new method of probing this area, and I'm excited about that. But even if you find a PFO, if the person has not had DCI, although they've obviously must have had exposure to diving, where you can't really say anything, right? But if they haven't had DCI, that still shouldn't disqualify them from diving. But if they have a PFO and they have had DCI of a serious nature, then we start discussing, should it be repaired or not? And in fact, are they fit to return to diving if they have residual symptoms? So then that becomes part of the discussion. And remember that a rest shunt really is a functional ASD. Once you want to know, you do a TEE, and in the meantime, avoid those straining maneuvers up to 2 hours after diving, because we know that's when the venous gas emboli are circulating. Try and reduce the gas bubble exposure and introduce stops. And I hope we'll start involving you guys in the ongoing research project. I think once we've identified a device and a nice protocol, it really could be an excellent study for us to undertake. And I think something that would be very meaningful and enjoyable. I've got a whole host of references that I'll make available to you on this presentation that really carves out the controversies that have sort of settled over the past 5 years or so. And as I say, if anybody wants the article, I can send it to you. Otherwise, you can get it online. Thank you very much.
After first reading of this article, which I received information from you, thank you very much, Frans, for this, but they reported they are using Melkor pulse oximeter. The problem is that they are showing only 2 first digits. They are not showing the decimal place. And so technically this is impossible to receive the 0.825 percent point as a decrease. So I do believe
area under the curve.
They were monitoring from the curves or from the analog output. That's why I like to be very careful about reading out from the device by itself.
Agreed.
Decreasing from 98 to 97 maybe means 99.1
correct
down to 98.7 or something.
Yes, yes, absolutely. And that's I may not have overstated it as I meant to, but the device was chosen because it had the output, and also the curves you saw allowed that area under the curve assessment. But thanks for bringing that out.